Dr. Ratan Gupta is available. Can you hear me?
Good evening, sir.
Good evening.
Yes,
You can hear me?
yes, sir. You're audible.
Yes. Thank you for joining. And this is an impromptu lecture sort of thing because somebody was not ready or something. So I just thought I'll spend 20 minutes about the talk. In about 10 minutes, we can discuss and we will quickly finish it. So I'm just sharing the screen. Can you see the screen?
Yes, sir. Yes, sir. Screen is visible.
And it's okay now?
Yes, sir.
Thank you for this opportunity. When the heart or the cardiovascular system is unable to maintain the tissue perfusion, despite optimal doses of inotropic agents and other supportive drugs, we need to think about temporary mechanical support devices and ECMO. So in the next 20 minutes, I'll go through the utility of echocardiography in such circumstances. If we talk about mechanical left ventricular assist devices, there are basically four different varieties. Basically, there are four different varieties. One is the intra-aortic balloon pump. The second one is the impeller. Third one is the tandem heart. And fourth one is the extracorporeal membrane oxygenation. We'll quickly go through each of them. An intra-aortic balloon pump is a device which is used inserted retrogradely through the femoral artery into the descending thoracic aorta. This diagram shows the correct placement of the intra-aortic balloon pump. Note that the tip of the intra-aortic balloon pump and the origin of the left subclavian artery, there is a distance of 1 to 2 centimeters. This is vital not to obstruct the left subclavian artery inadvertently. And typically the balloon is placed in the descending thoracic aorta. The volume is 30 or 30, 40 or 50 ml. Usually 40 ml balloon is used in most of the adult individuals. And the echocardiography comes handy to look at the guide wire placement and the passage of the IABP catheter as is shown on the right side of the picture. This is the long axis view of the descending thoracic aorta and the short axis view. And you can see the passage of the you can see the guide wire, and over which the IABP is threaded into the correct position. There is a case report of use of IABP in a patient with ischemic MR. And in this picture, the panels A and B show the IABP on position and off position as compared to this is on position in the apical long axis view and two chamber view. And this is the off position. You can see that the mitral regurgitation has increased, and this patient did not improve uh, with IABP, so patient needed placement of the mitral clip, and after that you can see that the MR has reduced, and this patient subsequently did well. And the IABP, I mean the echocardiogram was very useful in the management of this patient, both in terms of both in terms of the placement of the IABP, quantification of mitral regurgitation, and the subsequent mitral clip deployment. So in IABP, the absolute contraindications are aortic regurgitation, presence of aortic regurgitation, and the relative contraindications are aneurysms, dissections, and significant atherosclerosis. And the guide wire in the descending aorta can be discerned during the passage, and the IABP tip should be 1 to 2 centimeter distal to the left subclavian artery, or as already pointed out. The evaluation of IABP should include the monitoring of the patient precisely for the ischemic changes and the timing of the inflation and deflation. Coming to the next device, this is the impeller device, which is inserted again retrogradely through the aorta across the aortic valve into the left ventricle. This bit goes into the left ventricle, and the blood is sucked out, and then this is let out into the ascending aorta, and this reduces the left ventricular distension and decreases the left ventricular end-diastolic pressure and the left atrial pressures respectively. And this is the echo picture in a long axis view in the mid-esophageal window. About 4 centimeters of the impeller device is inside the left ventricle. And this is the aortic valve. This is the long axis of the ascending aorta, and the mitral valve, left ventricle, and the left atrium are seen here. This is the echocardiographic picture, and this is again a 3D mid-esophageal long axis view of the impeller device. And with color Doppler, you can see that the blood is taken out. There's a laminar flow here and is let out into the aorta. And in the deep transgastric view, in the mid-papillary region, you can see the impeller device within the cavity of the left ventricle, and there's a long axis in the transgastric window, again showing the impeller going into the left ventricular cavity. Coming to the left ventricle assist devices, this is the third option we have. Here you can see the LVAD inflow cannula correctly positioned. The heart is beating, and the blood is taken out from the left ventricular apex, and either using axial flow pump usually axial flow pump is used. The blood is pumped back to the ascending aorta, supporting the heart. If we have to monitor the position of the intratracheal septum, it should neither be too much towards the right, nor too much to the right. It should be centrally placed. And echocardiography is an important component of monitoring these patients. And this is the flow into the aorta. Laminar flow is seen. This is the outflow from the device into the ascending aorta. And you can also see that sometimes the papillary muscles may come in between the aortic, the inflow of the device. We have to precisely monitor and DA these patients, and right ventricular failure can occur in up to 30% of these patients, which is manifested as the septal deviation to the left side associated with right ventricular dilatation. And this is the flow of the cannula, flow or into the device. More or less laminar flow is occurring, and right ventricular failure can occur in some of these patients, which needs to be addressed. Either you have to treat the right ventricular failure, or actually once you have optimal preload and offload for the left ventricle, the septum comes to the midline, right ventricular function improves. If it does not improve, you might have to use nitric oxide, or think about using a right ventricular assist device. The next one is the ECMO. This picture shows that the father of ECMO, Bob Bartlett, whose picture is shown on the right side, and this is an ECMO survivor. This lady was overcome with emotion when she met her mentor, her treating doctor in one of the public meetings. And this lady was had an epileptic seizure and drowned in the bathtub, and she went into circulatory collapse and was put on ECMO, and she was on life support system for 14 days, and she made complete neurological recovery. And you can see the bubbly lady bubbling with life, which is a success story of the ECMO. And if we talk about ECMO, ECMO is a very complicated invasive technique to maintain the heart and lung or lung condition. I mean, support the failing heart or failing lungs or both by using extracorporeal devices. And the circuitry may look very overwhelming, and you can see the relatively deoxygenated blood coming out from the patient body, getting oxygenated and going back into the patient body and maintaining the oxygenation as well as perfusion. The components of the extramembrane carbon membrane are shown here. It is true for arterial ECMO. Venous blood is taken out, pumped through the oxygenator into the arterial system. And if you look at the types of ECMO, we have basically two types: veno-arterial and veno-venous. Veno-arterial again can be central, where we put the cannula in the right atrium and the ascending aorta, or it can be peripheral, where you can either use the femoral vein or jugular vein, and the arterial return is either through the ascending aorta or through the femoral vein. Veno-venous ECMO is a technique used to support patients who are respiratory failure. Again, there are three options are available as far as cannulation is concerned, which I'll be dealing with in next few slides. This is the veno-arterial ECMO configuration using jugular carotid axis. This is the venous cannula in the internal jugular vein going to the right atrium across into the inferior vena cava, and there are holes at the tip of the catheter which suck blood both from the IVC and the SVC right atrium, and it is passed through the artificial membrane oxygenator, and the oxygenated blood is returned back to the patient into the carotid artery on the right side. Coming to the next configuration, we have the femoral axis. Here the blood is taken from the femoral vein and is oxygenated and pumped back into the patient's femoral artery. And here, if you notice, if the patient has a native cardiac function, the blood which is coming from the left ventricle and the blood coming from the oxygenator, there's a point where they mix. And if the lungs are not functioning in this situation, patient's upper portion of the body will relatively get deoxygenated blood and the lower portion will get relatively more oxygenated blood, leading to what is called as Harlequin syndrome or red feet, blue head syndrome, or this may be scientifically termed as differential cyanosis. There are ways to tackle it. Either you improve the cardiac function and improve the go on to full ventilation, improve the cardiac function, and or you can use a Y cannula into this. Insert a Y connector here and take a bit of the blood from here and put it in the right side. That's called VAV ECMO, and that's a practical solution to this problem when it happens in the clinical settings. Coming to venous cannula options, we have basically three configurations. You can have the bicaval cannulation, that is the superior vena cava through the internal jugular vein, and the inferior vena cava through the femoral artery. In this configuration, you have to maintain a distance of at least 10 centimeters from the tips of the two cannulae, and you have to see that the IVC cannula is beyond the IVC-RA junction, just distal to the hepatic vein opening to the IVC, and the return cannula is in the a little above the mid RA position, and see that the return cannula gives blood into the tricuspid valve, which goes to the right ventricle pulmonary artery, and this is oxygenated blood going on to the right side and maintaining the maintaining the arterial oxygen saturation. The second configuration is the bilateral femoral cannulation. You put the drainage cannula through one femoral artery and the return cannula through the other femoral artery. And again, you have to maintain a distance of at least 10 centimeters between the tips. This to prevent recirculation. If you do not do in these two configurations, if the cannulas are too close, the oxygenated blood will be preferentially diverted to the drainage cannula, and deoxygenated will be entering the right ventricle. So this will be lead to failure of systemic oxygen saturation, and hence we have to. This is called as recirculation, and we need to avoid it by keeping a distance of about at least 10 centimeters with the tips of the cannula when they are in the bicaval cannulation configuration, as is shown on the A panel, or you have a bifemoral cannulation, which is shown in the B panel of the picture. The third option is you can have a single tube which has two lumina. One lumen takes blood from the IVC and SVC, and the other lumen returns blood into the right atrium in such a manner that the oxygenated blood goes to the tricuspid valve preferentially. This is pictorially represented in the picture on the right side. So this is with the double lumen cannula, as I said. This is a single tube which has two lumina, one for drainage and one for return. The return cannula carries oxygenated blood, and this blood is directed towards the tricuspid valve into the right ventricle. So coming to the role of echocardiography, in ECMO, we need to use echocardiography in terms of patient selection. For example, you need to look at what is the cardiac condition, whether the patient needs VV ECMO or VA ECMO. Not only that, is there any contraindication for arterial cannulation? For example, aortic regurgitation, presence of atrial septal defect, etc., must be clearly delineated before we institute these invasive techniques. The echo is handy in Insertion during insertion and correct placement of the cannula, monitoring during support, and detecting complications. Absolutely important during weaning process. Contraindications, as I said, aortic valve regurgitation is an absolute contraindication. Aortic dissection is also um, contraindication. In the presence of aortic dissection, if at all you are using the ECMO, you have to be extremely cautious and go for the ensure that your cannula is in the true lumen. Some of the difficulties which we may encounter when cannulation is that atrial septal aneurysms, atrial septal defect, and extensive hearing network and pacemaker leads may impede or make the cannulation on the right side difficult. And this is a schematic representation of the bicable cannulation. This I already alluded to. And the position of the IVC cannula can be looked into when you look at the bicable view using the Francis field echocardiography. Central veno-arterial ECMO with the aortic cannula can be seen in the aortic upper esophageal aortic arch, short and long axis view, and also in the aortic ascending aortic long axis view at 120 degrees using mid-esophageal window. This I already said. And coming to Avalon cannula, I said it's single tube which has two lumina. One lumen allows the deoxygenated blood to drain from the IVC and SVC. Second lumen allows oxygenated blood to return to dilate directed towards tricuspid valve. This reduces. This requires precise placement of the return blood towards the tricuspid valve. And coming to the monitoring of the patients using echocardiography, we have to monitor for left ventricular dilatation, pulmonary congestion, and for example, the patients on peripheral VA ECMO, especially the left ventricle may get dilated, and you have to monitor for the valve opening, and there may be stagnation of blood in the left ventricle, and spontaneous echo contrast may be seen. Unloading of the left ventricle may be necessary in VA ECMO. You can use any of these methods. I think in our center, I think the left apical vent is commonly used. And the inferior vena cava can also be visualized using echocardiography. And next important component of this monitoring these patients using echocardiography is detection of complications. There may be cannula related problems or anticoagulation related problem. The cannula may be displaced or obstructed, and there may be thrombosis as is shown here. There is a clot here in the left ventricle. This can be detected, and spontaneous contrast is seen here. There's a clot in the aortic valve here in a patient who is on ECMO, and there may be formation of tamponade, which becomes evident when you're trying to come off the ECMO. Regarding malposition, the atrial septal aneurysm after the cannula, and similarly, when you're using right ventricular assist device, the tricuspid valve leaflet may be sucked and may obstruct the cannula when you're using the right ventricular assist device. Coming to weaning, once there is recovery of the cardiac functions in VA ECMO, if the LVEF is 25% or more, and the aortic VTI or the LVOT VTI equal to or more than 10 centimeters, and the S prime is greater than 6 centimeters per second, and there is in general improvement and absence of lactic acidosis or improvement in the lactic acidosis. We might think of weaning these patients, and here the monitoring of the heart function becomes very important in terms of determination of the LVOT VTI. For example, in this case, the deep transgastric view of the left ventricle is chosen and pulse wave Doppler is inserted at the LVOT, and you measure the LVOT VTI. In this case, it is about 8.3, which is less. If it's 10 or more than 10, it's a signal for us to think about weaning the ECMO. The septal velocities may also be used, and this has been used, which has a significant prognostic value for predicting weaning extracorporeal life support systems. In conclusion, the use of echocardiography is absolutely useful in all types of mechanical circulatory devices, temporary mechanical circulatory devices. For example, starting from IABP to impeller to LVAD insertion to institution of ECMO. At all these, in all these situations, the use of echocardiography is extremely helpful. And when you talk about ECMO, patient selection, insertion, and positioning of the cannulae, and monitoring of the patients on some extracorporeal circulation, that is extracorporeal membrane oxygenation, and detection of complications and weaning of ECMO, and further monitoring after weaning of ECMO is weaned. At all stages, echocardiography is extremely useful. With this, I conclude this impromptu talk about use of ECMO, and is open for discussion.
Thank you, sir. That was very insightful talk. Just want to add to what you already
Please,
said.
please.
Yes. Apart from whatever we have mentioned, we can also use the ultrasound to detect problems with the lung, especially during veno-venous ECMO. During the initial phase of veno-venous ECMO, we can also use the echo to assess the preload and filling of the venous system so that you can optimize the cardiac output. And subsequently, when the patient's underlying lung condition has recovered, you can try to keep the patient dry so that it eases. You are ready to wean the veno-venous ECMO. You can assess the IVC size. You can also take a look at the pleural cavity and make sure that there's no effusion, because that would help in weaning the patient from the veno-venous ECMO.
Correct.
So these are few additional points I want to add.
Yeah. Use of ultrasound to look at the lungs. Yeah, absolutely correct point. Their lungs may be congested, maybe there may be pneumothorax, there may be pleural effusion. So all these things can be easily detected using ultrasound of the lung. Yeah, absolutely correct.
Yeah.
Any other questions or comments?
Good evening, sir.
Yes, madam.
This was very useful for all of us. I had some doubt. You said
Yes.
about ischemic MR patient not improving with IABP, but it had that valve needed mitral clip insertion.
Correct.
I just wanted to know why IABP, or how was it helpful in deciding that IABP alone is not enough? Or is there any role of IABP to decide whether patient needs mitral clip? I had such doubt.
Yeah. This patient had acute myocardial infarction and was subjected to stenting procedure. And after that, he continued to be in low cardiac output and cardiogenic shock. And IABP was inserted, and in the TE, it was observed that the mitral regurgitation reduced with IABP. But there was no way to remove the IABP, because as soon as the IABP, the augmentation was reduced, the MR became severe and patient became went into shock state again with hypotension, oliguria, lactic acidosis. So it was decided to put a mitral clip to sort out the mitral regurgitation, which worked out very well for this case. And then subsequently, the patient's IVP could be removed without any issue.
It was a very useful tool as a diagnostic also, not only therapeutic.
Yes, yes. Yes.
Sometimes they say with IABP we can look at the aortic flows with or
Yes,
without
yes.
support. Like when we want to wean from ECMO, LVOT VTI should be at least 10 centimeters per second.
Correct.
I think IABP also may be useful in that way.
Yes, if
When
the patient is already having IABP, it should be continued.
yes, sir.
And especially in veno arterial ECMO, if the patient is already having IABP and goes on to ECMO, especially in VA ECMO, the IABP is left alone because it will help the unloading of the left ventricle.
Both supports will be there, sir.
Both supports will be there. But some of my colleagues don't agree with that, because when you are using IABP with femoral arterial cannula, the arterial flow into the aorta will impose afterload to the left ventricle.
Yes.
So the LV will find it difficult. So use of IABP to aid heart's unloading is useful. But some of my colleagues argue that if you do that, the Harlequin syndrome may be more obvious, because if the heart is functioning, whatever blood is going through the LV, it will be pumped out from the LV into the aorta, and that blood will go to the upper story. Ratan, do you agree with that?
Sir, that may be one of the problems because your cardiac output might improve with IBP in position. The other advantage probably with IBP is the flows on ECMO would become it will not be flat line. It will be pulsatile. So that might be an advantage theoretically. The other concern is when IBP is there, the femoral flows might be a problem with the large cannula in place. So you can have a localized problem with the limb circulation. So it becomes complicated there. So generally, if there is a IBP, you can either leave it or even if there's a limb circulation compromise, then probably it might be better to take it out.
No, if there's a compromise circulation, no doubt you must remove it, and if necessary, you recite it. But if you talk to Julius, he does not like to use IABP on ECMO, VA ECMO, especially peripheral VA ECMO. And his reasoning is that the area of mixing of the ECMO, the blood, oxygenated blood, and the native cardiac output will move down the descending thoracic aorta because of the decreased afterload with the use of IABP.
Yes, sir. I think probably when we are using a central ECMO, when this problem is not there, then I think we can probably continue with the IABP. Other thing is, sir, this Avalon
otherwise, good evening, sir. Even otherwise, the central, if not central, even the can change over the site now for this one. sites of this one jugular, or that also advisable.
In adults, usually when you do
Sites of
peripheral ECMO, it will be femoral arterial cannula, which will return the blood to the patient from after oxygenation.
So aortic regurgitation, it's contraindication for VA ECMO.
Yes.
Is it a contraindication for VV ECMO?
No, not really, not really.
And what about mitral regurgitation, sir?
Mitral regurgitation is not a contraindication. It's not mentioned in the contraindication, but in the one of the editions of Kaplan, I think previous to this edition, he has also mentioned that if there is a HOCM, that is hypertrophic cardiomyopathy, it is a contraindication for ECMO because it will reduce the SVR and increase the outflow gradient.
Yes.
But other textbooks have not mentioned it. Only one of, I think, recent edition of Kaplan has mentioned, if I'm right.
Sir, VA ECMO generally should increase the afterload.
Yeah.
Yeah. Generally, the afterload goes up when we are using ECMO. So probably.
Yeah, that is the drawback of the VA ECMO. Yeah, that is true. But ER will worsen because
yes,
the blood is going against the native blood flow from the aorta to the descending thoracic aorta.
Yes, sir.
So the regurgitation will worsen and LV will be distended.
Sir, how about resuscitating a patient who's on VV ECMO?
Resuscitation. This patient should, you have to follow the ACLS guidelines because the patient needs, has to, you mean to say cardiac arrest resuscitation?
Yes, a cardiac arrest resuscitation.
In
During
VV ECMO, there's no issue. You have to use the traditional ACLS guidelines, cardiac massage, and shockable or non-shockable. Depending on that, you have to use adrenaline. If it is shockable, give shocks and restore the normal sinus rhythm. If it is VA ECMO, you have to go on to full flows and then try to restore the rhythm. You can give shocks. But if it is central ECMO, you have to be extremely careful whether you want to open the chest and resuscitate, or here in VA ECMO, there is some sort of a little bit of comfort zone is there. So you need to restore the sinus rhythm as soon as possible to be able to have a normal aortic valve opening and closing, so that there is no clot formation there.
Yeah. I think in case we have a VV ECMO, we'll have to continue with the normal resuscitation, and we can try converting it from VV ECMO to either VAV ECMO or VA ECMO, so that we can establish some flows, if it is possible. It may not be very easy to do that.
Yes.
If you can get a femoral arterial cannula in somehow, then you can probably try converting it to VA or VAV ECMO.
Yes. That's right. Any other questions? Comments?
No, sir.
If there are no questions, can we conclude it?
Yes, sir. Thank you, sir.
Thank you. In the last 40 minutes, what we have done is we have discussed about the use of ECMO, echocardiography in temporary mechanical circulatory devices. First IABP, then followed by Impella, then LVAD insertion, and then the ECMO. And we conclude that echocardiography is an important component of both during initiation, maintenance, and weaning, and further surveillance of the patient when we are using the mechanical circulatory devices. Thank you so much and good night.
Thank you, sir. Thank you for that.
Thank you.
Thank you. Thank you.